Again, I want to thank you all for joining us today. We have a really great webinar on tap. It's Understanding and Managing the Post-Lung Transplant Journey. We've got three fantastic speakers joining us today. We've got Dr. Maria Crespo, we've got Zaleski, and Evan Rood are joining us today, and we're very excited to be partnering with the Pulmonary Hypertension Association for this webinar. And I'd also like to thank our sponsor, United Therapeutics. Before we get started with intros and the webinar, though, I do want to go over a couple just bits of key information just to make sure everyone is logged in correctly. If you are logged in correctly, you should be able to see my face and the face of our other presenters, as well as hear our audio. If you are having any audio or visual issues, please direct message myself or one of the other panelists, and we can take care of those issues for you, or you can try logging out and logging back in. If you're viewing this presentation via tablet or phone, you may have to scroll to the left or right to be able to see the presentation or the presenters while speaking. I do also want to mention that today's webinar is being recorded, so if you'd like to catch that, definitely check out our YouTube channel. It will be on our YouTube channel by Friday of this week, so feel free to jump on there and see the recording. Also, the National Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. It's going to be a jam-packed session today, so I do encourage everyone to put all of your questions into the Q&A box or the chat box, and we'll be sure to get to those at the end of the presentation. So first, I'd like to introduce our patient advocate, our first speaker of the day. It's going to be Evan Rood. Evan Rood was diagnosed with scleroderma in 2014. And in 2016, he began to experience heart failure as his disease progressed to the point where he needed a heart and lung transplant. Together with the team at Penn, he was able to get a lung and heart transplant, and he underwent that procedure in 2018. Since then, Evan has been a strong advocate of the scleroderma community. He's even spoken as one of our keynote speakers at last year's conference, and I'm very excited to invite him to today's webinar. Thank you, Evan. The floor is yours.
Hi, everyone. And thank you, Angel, as well as our other discussion panelists today, Derek and Maria, Angela, and Sarah. And thank you so much for your help. And thank you all for joining the webinar today. It is so great to see such a large and welcoming community associated with the National Scleroderma Foundation. The kind of questions that I'm asked is just tell us about your story of and your journey through scleroderma. And the one thing that I think I really like to open with is that it's not my story and it's not my journey. There are countless people, doctors and nurses and family and my sister that are all part of this that kind of have gotten me from where I was then to where I am today. And it's really important that we don't just highlight my words, but we highlight much more than that, because without all of those other voices along the way, I wouldn't be here as happy and as healthy as I am today. And including other patient advocates with my disease or with similar things as me, coming and talking to me while I was in the hospital or prior to transplant, and helping me through this journey, just as people helped them. And so here I am kind of extending and continuing that tradition of kind of passing on what we've learned from the unfortunate of illness to illness. But it is so important. Like Angel said, I was diagnosed with scleroderma in 2014 after I would say 4 years, 3 years really of symptoms that had no clear diagnosis. I was attending the University of Oregon in Eugene, and although I had a full battery of tests, I saw dermatologists and internists and doctors and even a rheumatoid arthritis doctor. I went undiagnosed. And when after graduating, I was as ill as I could be. Essentially just on a regimen of Tylenol because that was the best thing that they could tell me to take. I came back to Seattle, um, and with a kind of on a whim, got an appointment with an internist named Dr. Daniel E. First, and he diagnosed me within 30 minutes of meeting with me. And it really was, it's like 3 years, and all of a sudden, here I have a diagnosis, and the diagnosis, to be to be frank, is scary. It's very scary. Um, and of course, they upfront tell you what your life might be like, and it is a shock, and it definitely is not something that that you want to hear, that your life is forever changed. As a Clearly, as a recent college graduate, that my life would not be what I anticipated, was definitely something that I had to work through. But as I just stated, that my journey is not just my journey. It is a journey with a bunch of different people, all helping out us, helping me and helping our community. Um, and I realized very quickly that I was not alone, and that no patient in any illness is alone because of the incredible care that we get from our nurse and doctor and specialist teams and our family. And specifically, for me, it was my parents and my sister. My sister, who is 2 years 8 months younger, immediately became my everything. We've always been close. And we went to different colleges, but we always stayed in really tight and close communication. And when it finally came to be in 2016, where I was really starting to feel the effects of my disease, both pulmonary hypertension and scleroderma, and I had to stop working. um she was there, and she attended doctor's appointments with me. And when it was finally decided from my team at University of Washington, because I live in Seattle, that I needed a transplant, um and we started looking and we started doing research. And none of this was alone, by the way. This was with the generous help of many different people from the hospitals and from the community. um she said, well, I'm going to be there every step of the way. And when I was finally accepted into a program, anywhere, not in Seattle, and definitely not anywhere on the West Coast, it was at University of Pennsylvania. um she she literally, she quit her job. She quit her job, and she essentially moved with me to Philadelphia, and we didn't have a timeline, and she said, I'm here with you. um and that's the most important part, of illness, is having that support system. um and I know it's that support system doesn't look the same for everyone. But you would be surprised at how willing people are to reach out, to help out in any way they can. Yeah, there were definitely moments of me feeling alone, um, and that days that I just felt like this wasn't gonna turn out very well for me. Um, And it honestly just took out, took the courage to reaching out to one person. And then all of a sudden, all of these doors opened because everyone wanted to show their appreciation and wanted to help. Um, and that got us to Philadelphia, and from Philadelphia, it got me through transplant and to today, where I'm back in Seattle. Have been back since 2019. And I have a fiance, and we're getting married in August. And I have a wonderful job, and yeah, and I have my health, which I can honestly say is because of the incredible care I had at UPenn. Um, and although that wasn't easy, um, I definitely had my fair share of challenges through my hospital stay. But the testament that to Derek, who was joining us today, and Maria Crespo, um, how I've stayed uh, uh, fairly tight with them, and I do go back to Philadelphia every year to kind of have my annual checkups, but I've retained this friendship with them, and it just goes to show how much they care, and how wonderful this community is at at essentially bringing us together and holding us. And I think that's such an important part of the journey for everyone, is to know that you're not alone, and that friends happen everywhere. Um, and yeah, and I just love to think that without that family and the courage to ask for help, I wouldn't be in this situation that I am today with the health that I have. Um, from 2014 to today, in terms of just my quality of life changes, transplant was by far the right decision for me. Um, I In terms of, just day-to-day life, it's a regimented drug schedule where I take my prescribed medicines throughout the day, and I stay active. Um, and there are definitely sacrifices that I've had to make. Some things that I just know that I can't do anymore. But all of those things are worth having what I have now, which is life and a future, which at one point I was told maybe I wouldn't. Um, and also just I think a part of it for me also is, prior to this, I had, not that my life goals were changed much, but I was definitely very much focused on kind of a one track work mind. And now I am, I there I've changed in what I think is most important in my life. And that, is friends and family, and keeping in touch with people, and I directly attribute that also to going through this process of transplant. And If you are currently considering lung transplant, and you're looking for an answer to illness that you have, from my perspective, definitely talk to your care team and have it as an option. Um, it's not easy. It's scary, and it is hard work. But it is definitely worth it. As it has been for me.
Thank you so much, Evan. That was fantastic journey, and definitely making me want to call my sister and thank her for all the great things she's done for me too. But
Yeah.
thank you so much, Evan. Next, I'd like to introduce our next speaker, Dr. Maria Crespo. Dr. Maria Crespo is a professor of medicine and the medical director of the lung transplant program at University of Pennsylvania. Dr. Crespo is a longtime advocate of the scleroderma community and has spoken at several local and national educational events for our community. Thank you for joining us today, Dr. Crespo. The floor is yours.
Yeah, thank you. Thank you, everybody. And I want actually just to thank the National Scleroderma Foundation as well as the Pulmonary Hypertension Association for inviting me to be part of this patient webinar and to talk about the post-lung transplant journey and systemic sclerosis. And I have asked Angel to help me with the slides because I have been having a lot of trouble actually like to post them myself. So you go into the next one. And again, like twice, yeah. Yeah. So again, yeah. So you got the lung transplant and now you are going to start, I mean, your post-transplant journey. You know, some of the things that I'm going to talk, I mean, they are highlighted in here, and is you know, the phase from inpatient to outpatient, the outpatient management, some of the different medications as part of the post-lung transplant, the lifestyle and quality of life, as well as the importance of the maintained health care. You go into the next one. So once the patient has the surgery, they will go to the intensive care unit. What is the timing in the ICU? It is very difficult to predict. I mean, they can be from 2 weeks, I mean, to what Evan was mentioned, it can be actually like longer. You know, patients who had, you know, a combined lung and heart, I mean, it takes a longer time for the recovery phase rather than if you only have a lung transplant. But those patients that they have been much sicker going into the transplant with more comorbidities. And one of the things that happen in patients often with scleroderma is that they have pulmonary hypertension, and that right ventricle has been struggling for some time, and it has been actually like not strong enough. I mean, it has been very dilated. So it takes time until it normalizes the pulmonary pressures after the lung transplant, and patients, they have to be more supported on the ventilator as well as with different medications until it takes time actually for the right ventricle to remodeling. But once the patient is no longer required the ICU, they will go to a step-down unit, and if the patient is clinically improving, the next step is that before discharge, the patient will be evaluated by the physical therapist. If the patient is strong enough, I mean, that then the patient will start outpatient pulmonary rehab. In other words, the patients will go to an acute rehab facility until they get strong enough that they can initiate the outpatient rehab. During that phase, I mean, there will be a teaching with the patient and the support group. I mean, with the outpatient care team, with the nurse, I mean, nurse practitioner, as well as the transplant pharmacist, and the patient will now embark into the world of the outpatient with clinic follow-ups and the surveillance bronchoscopies that I will discuss more detailed later on. The next one. Without any doubt, I mean, the first year it can be very intense, and as Evan alluded very well, I mean, your support and caregiver is key in your journey. The patients, they will have follow-up clinic visits, and during the first 3 months, and it varies from patient to patient depending on how well they is doing post-lung transplant. But those visit clinics is once a week. And every time the patient comes to clinic, we'll have chest X-ray, we'll have the pulmonary function test, just to make sure, I mean, that the lungs, they are actually like recovering well. And also blood work, I mean, just, you know, to check for the immunosuppression level, just to make sure that they're at goal and the patient is not at risk of not having protected the new lungs. But at the same time, for some of the side effects of toxicity related with some of the new medications, like that the white count is good, I mean, the red blood cell count, and also particularly the kidney function. If you don't mind to pass to the next one. I mean, so after the lung transplant is, patients, they don't have any longer, I mean, the interstitial lung disease, neither they will have pulmonary hypertension, but they will still have the scleroderma. So that's why it's very important to have the previous one, I'm sorry, to have a very close follow-up with the rheumatologist to make sure that the rhinos, I mean, is well controlled. I mean, the skin, if patients that have some of the joint actually like maybe problems. Also, the rheumatologists, they are very good in managing also and taking care of the osteoporosis. Like you all well know, I mean, scleroderma affects the GI tract from the esophagus all the way to the stomach and the small bowel. So have a very close follow-up with the gastroenterologist for all the complications or symptoms, GI symptoms related with the scleroderma is very important. Yeah, the number of medications, yeah, I mean, I'm not actually like, and Evan knows very well. I mean, it can be as big as 20. That doesn't mean that it's going to be forever as the patient is getting stronger and as the time passes by after the lung transplant, the number of medications that will be actually like much lower. The patients also will have their own homework. They need to check actually like every day at home the vitals with the heart rate, I mean, blood pressure, the temperature, and also spirometries at home. And they need to communicate with the outpatient team and care team just to make sure if there's any abnormalities or any concerns. The next one, please. So the different medications that the patient would have, is actually like in here detailed. They are from anti-rejection medications, so infection prevention, I mean, pain medications, especially just the early post-surgery incisional pain. Some patients, they actually were diabetic prior to the transplant, but some other ones, they were pre-diabetic, and immediately after the lung transplant with being on high doses of steroids, they might develop very high glucose. I mean, and they might require to be for some time on insulin. The next one, please. And this is the different classes of immunosuppression medications from the calcinum inhibitors. I mean, either the patient will be on tacrolimus or cyclosporin, the antimetabolite that scleroderma patients they know well, which is the mycophenolate, and then the steroids. The next one. Also, patients that will have to have infection prevention medications as prophylaxis for antiviral, antifungal medications. I mean, sometimes they are oral or they can be just because they, medications like some solutions to prevent any thrush, and they will be for life on an antibiotic to prevent a type of infection that is called pneumocystis carinii. The next one. So the way that we know that how good actually like the new lung is doing is that by doing during the first year what we call the surveillance bronchoscopy, and this is regardless whether the patient is doing very well without any symptoms of cough or shortness of breath, and regardless whether the pulmonary function test is stable. And with this bronchoscopy, we do an inspection to make sure that with the area of the bronchos where it was connected, the new lungs is healing very well. We will also check for infection, and the patient will have transbronchial biopsies because that is the way of knowing whether there's a rejection or not. And here I actually have the timing. But I mean, it actually varies between one institution to another one. So this is the one that we have here at Penn. Why only the first year, the surveillance bronchoscopy? Because most of the studies have shown that the high incidence of acute rejection, it occurs during the first year after the lung transplant. What happened after 1 year? It won't be surveillance bronchoscopies, it will be clinically indicated. That means that when the patient has any symptoms, there's some abnormalities on the chest X-ray, and then when we notice that the pulmonary function test is actually getting actually like much lower. These are actually like outpatient procedures, so the patient doesn't need to be admitted, and they are done under general anesthesia, so the patient is going to be very comfortable. Like any procedures, there can be some side effects. Some patients actually they develop fever. They develop also like some drowsiness or groggy because of the anesthetics, and it's normal for a few days that the patient, whenever they cough, there will be some blood tinge in the sputum. The next one, please. Healthcare maintenance is key after the lung transplant. Patients, they need to have a very well control of the blood pressure as well as the diabetes. We often send patients, to our colleagues in endocrinology, especially whenever, just to make sure that the diabetes is well controlled. Why is that? Having the very bad blood pressure and uncontrolled diabetes, that also can affect the kidneys, and we don't want that actually like to happen, particularly because patients, they are already taking anti-rejection medication called tacrolimus that can be at risk of developing problems with the kidneys. Bone health is actually like very important, and the management of osteoporosis. Most of the patients, they have been on high doses of steroids before the transplant, for the treatment of the interstitial lung disease. But after the lung transplant, patients at the beginning, they will be on high doses of steroids, and the prednisone, even though it will be decrease the dose over time, but it becomes actually that very brittle, the bones, and we don't want patients to be at high risk of fractures. And some of those fractures, they can be actually like vertebral fractures or compression fractures, which they are very painful and actually like impede for the patients actually to rehab after the lung transplant very well. And that actually like it can impact negatively on the lungs. Because the patients, they don't take very deep breaths after, and it can actually cause a risk of infections. Vaccinations, they have to be up to date. Also, other care like dental and eye is very important. Also, it's very important, to be up to date with the cancer screening from mammogram and pap smear and to PSA colonoscopy. And there's a high incidence of skin cancer after any organ transplant, and that's the reason why we recommend patients, to avoid prolonged sun exposure. When they also go to places, and being exposed to the sun, just to make sure that they use a high actually like skin actually like blocker lotion, but at the same time they need to see a dermatologist at least on a yearly basis so they can do a thorough skin cancer screening. The next one. And talking, as I mentioned before, about the osteoporosis screening, we do blood work just to make sure that your vitamin D is good. Other important minerals like the calcium, phosphorus, and magnesium, they are very good. And then patients, they go through this machine, which is a DEXA scan, where they actually check the degree of osteoporosis. The next one. So we know that after the lung transplant, patients, they are going to be very immunosuppressed, and the exposures, they matter, and preventive measures can help. We want the patient to be safe, but has a good quality of life. So we want not to make sure that patients, they just live confined inside actually like a bubble or a cascade. The next one. So we can start with the home. Obviously the risk of every patient, it varies. Depending on where the house that is, if it's in a rural area, versus actually like a big city. In a rural area, they might live close to different actually like farms. Maybe the neighbors, they have chickens, or they have some other animals. They have a lot of barns, where there's a lot of mold exposed. some patients, they have big families and they have a lot of brothers, sisters, cousins, and a lot of children, and grandchildren, which they have a lot of, they're actually like a risk of infections because of that. But also they like to gather together, in separate, dinners or celebration. It's very important to know the water that the patient is consuming, where it's coming from, and also like the pets, which pets the patient have. Going to the next one. So living with a school or with daycare age children increase the risk for exposure to communicable diseases, and preventive measurements are really essential. When a patient is, when a kid is sick, you have to wear a mask, but make sure, that the kid is being seen by a pediatrician to make sure what type of infection the kid has. At the same time, also, it's essential that the kids, they are up to date with all the immunization, and hand washing is a key preventable measurement. The next one. We all like pets, but there are some of them actually that they can be risky actually for us. And if you go one by one, clicking, there are some of them like the next one, that they are actually like very harmful, for an immunosuppressed patient, and it can be actually like associated with a lot of secondary infections, and that is something that is important. Sometimes whenever we do the pre-transplant evaluation on patients, we want just to make sure what type of pets they have at home, and sometimes they have actually to give actually some of these pets, to their friends, because it's going to be very dangerous for them after the lung transplant because of the immunosuppression stage to continue to having these pets. Yeah. So the next one. After the lung transplant, also, patients, they have to be careful on what food that they take. There have been some food outbreaks. Patients, they have to avoid any raw food or uncooked meats, as well as raw uncooked eggs. Patients, they can go to restaurants, but if you go to a restaurant, don't actually like go and with your plate, to a salad bar, because you don't know how good those lettuce, tomatoes, or other vegetables, they have been like cleaned, so you have actually like to avoid it. Whenever you are at home and you have you use cutting boards, you have just to make sure that it can get very contaminated if you got a chicken actually, and then afterwards use some other food actually, like without having been cleaned very well the cutting board. So these are things that they are important. The next one, please. So we all like the recreation and the swimming, but there are two of them. If you can click twice, yeah, there are two of them that you should avoid. But going to the beach, and swimming in a swimming pool, they're actually like without much risk as the other ones. The next one. So what is the truth about gardening? The patients, they can take care of their plants, but there's risk of infections. And precautions have to be taken care. Using gloves, skin coverage and mask, and then some anti-tick actually, like protection with teeth. So patients actually, when they do gardening there can be maybe some deer close by, so there can be risk of developing like Lyme disease. Because of the tick bite, and the other one also, there's a lot of mold actually that you can actually like either from the dirt or just actually like maybe some dry leaves. And you can actually like breathe all of this and get into troubles with developing infections. The next one. We all know about the marijuana side effects. It makes us actually like some side effects with mental impairment, and they actually have side effects or interactions with some of the medications that patients they take after the lung transplant, particularly with tacrolimus. And they, produce, heart arrhythmias and kidney injury. The most of the risk in the different forms of marijuana is when patients they smoke, because they actually you can actually smoke mold, because usually it's contaminated with aspergillus, and we actually don't recommend actually patients after lung transplant to smoke marijuana. What about the edibles marijuana? That is permitted, but it has to be those edibles marijuanas prescribed by a physician who has the license to prescribe marijuana, and not actually having or getting that edibles marijuana from the street. The next one. So safe sex keeps you safe. That is true. There's a lot of different sexually transmitted infections, and the using of protection with condoms is key. The next one. We have many patients that as they get far away from the transplant and they are clinically doing well, they want actually to go to other continents. We always want to know which continent is going to be. There's continents, which they have a lot of high risk of malaria, or there are actually some other continents where there's a high incidence of yellow fever, and we actually recommend patients to avoid those countries. Why? Because patients, they cannot get protection by getting a yellow fever vaccine, because it's a live vaccine. Always we recommend patients to be evaluated before any international traveling, to be seen by the transplant infectious disease traveling team, where those patients actually they make sure that all the vaccinations and especially some patients that they might want to go to Africa, and make sure that they start on the anti-malaria prophylaxis before they travel. It's very important also. You never know what is going to happen, and if there's going to be, any delays on your return back from that country. So carry all the medications and make sure that at least, that you have good insurance in case that you get sick and you need to come back to the country. Next one. And we want just to make sure, that we always actually ask, patients, just we give them a prescription for azithromycin for the traveler's diarrhea, some screen and for all these mosquitoes and all of that. And obviously patients, we don't recommend patients to actually take any ice, ice actually because of high risk associated with Legionella. The next one. The next one, yeah. So it's very important that patients, not just actually the patients, but also the household, they need to be vaccinated. And one of the things that is important is that whenever actually either, we have patients that have children, that they are actually infants, or patients they have grandchildren, that we need just to make sure actually that they have to be away, when the children they get any live vaccine, either the live influenza vaccine, the polio, or the smallpox too. And most of the time is contact. So we recommend at least be away for at least 3 to 4 weeks. From those children. The next one. We know that scleroderma patients, they have esophageal involvement, and it causes esophageal dysmotility and also reflux. So scleroderma patients before the lung transplant, they have been always very careful about what actually they should do, to prevent worsening the reflux and aspiration, but it's going to be more strict actually this lifestyle modification after the lung transplant. And the reason for that is because often patients, they can have what is called silent aspirations. So they don't even notice that they are aspirating, and this aspiration is not food. It's basically just the acidity of the reflex. And there's a lot of studies showing that these constant silent aspirations, they cause a lot of damage on the new lungs, and to the point that patients, they are at high risk of not just aspiration pneumonia, but also developing chronic rejection to the point that they can even lose the allograft. So in here is obviously the things that we all like the most, including the chocolate, but there's some other actually like food which has a lot of acidities which has to be avoided, also including obviously the caffeine and any carbonation, also like liquid, eat small pieces, and weight actually loss. If patients, they gain a lot of weight, that weight, it goes into the belly, and that puts the stomach higher, so the risk of reflux is much higher. Going to the next one. And then obviously, like there are things like no smoking, avoid alcohol, sleep always with the head of the belt elevated, and even one of the gastroenterologists mentioned that the sleeping in the left decubitus position also prevent reflux too. But actually, like patients, we actually recommend at least to wait 3 to 4 hours, after eating before they go to sleep. Yeah. The next one. So in conclusion, there's many studies which have shown that the lung transplant among patients with scleroderma is comparable to the outcomes and the quality of life to other interstitial lung disease, non-scleroderma related patients. It's like a breath of life. But scleroderma patients, they have an increased lung transplant comorbidities with secondary pulmonary hypertension and extrapulmonary conditions, which might have a prolonged hospital length of stay, early transplant evaluation before they get too sick is actually like essential to have a good post-transplant outcomes. The next one. A multidisciplinary team in the evaluation and longitudinal care post-lung transplant is important, and particularly for scleroderma, as I mentioned, is the rheumatology as well as the gastroenterologists. Having a great support, as Evan alluded, is key for the success and well-being. It's important that you take good care of yourself and be up to date in vaccinations and health maintenance. But the aim actually is for you to end up having a very good quality of life. And the next one. So I wanted to acknowledge Evan for being an inspiration to other lung transplant patients, and for motivating us, to go above and beyond in the work that we do, for helping more patients with scleroderma. The next one. And I want also to acknowledge the Penn Lung Transplant team. Thank you so much.
Thank you, Dr. Crespo, for that fantastic presentation. Next, we'll go to our final speaker, Derek Zaleski. He's a physical therapist at Penn Medicine and a vital member of the lung transplant team, where he focuses on promoting strength, endurance, and flexibility for his patients. I did a little bit of digging, and Derek has been described as, and I quote, "hands down, bar none, the most caring and gifted physical therapist I've ever worked with." The floor is yours, Derek.
Well, thanks, Angel, for the introduction. Thanks, Evan and Dr. Crespo, for getting things started. Evan, I know you alluded to the hard work that you had in your pre and your post lung transplant phase. And for those that want to see what hard work looks like, there will be some videos of Evan's journey in the post lung transplant process here. I'm just going to share my screen and we'll get started. All right. Angel, can you see my screen okay?
Yeah, looks good.
All right. So by the end of this chat, we're going to describe, you understand kind of the phases of recovery after lung transplant and the necessity and benefits of a comprehensive outpatient pulmonary rehab and physical therapy program post transplant. This slide has a lot of crossover with what you guys just learned about, but at this stage in the process, for those who have undergone lung transplant evaluation, you are listed for lung transplant, and you're either coming in from, you would get the call for that an organ or organs have been at that there are a match for you, and in our institution you're coming in from home, or you're actually admitted waiting for your lung or combined organ transplant. Evan, I don't know if you mentioned it, but Evan was actually waiting in the hospital, I believe, from January until at least March, if not April. This is Evan's transplant month, if I remember correctly. But Evan was hospitalized pre-transplant, waiting, essentially too sick to be kind of monitored outside the hospital, so we had to bring him in. Once you can see right in the middle of the screen, you get lung, if the organs are deemed viable by the surgeon and the lung transplant team, you will get your lung transplant, where you're then transferred immediately to the CT surgical ICU. Like Dr. Crespo said, the recovery there is variable, and you'll see some videos shortly about what we mean by that. Once out of the heart and vascular intensive care unit, you progress to the cardiothoracic step-down unit. You're there until you're deemed kind of ready medically and physically to leave the hospital. From there, you go to the acute rehab setting, and then you go to the outpatient post-transplant rehab. From there, the average length of stay, kind of to circle back to the heart and vascular ICU, at the time that is, it's a large range, but most of our patients at kind of Penn Medicine do well. Our average length of stay in the ICU is approximately a week. There, you're on medications for blood pressure support. You're on a mechanical ventilator. You still cannot breathe on your own, and you have multiple chest tubes in place. From a physical therapy standpoint, it's all about working with the intensive care unit team, the lung transplant team, to progress with kind of functional training. And that's very simple functional mobility type of exercises. Standing and getting out of bed into the chair, and slowly starting to walk, in our case with a platform walker, and with as much assistance as necessary. Some other bullet points here. You saw the Moveo. For those that are unfamiliar with this, it's a portable squat table, as well as a tilt table, and we do have a video that shows this as well. And we begin the breathing retraining exercises, airway clearance, and then this last bullet point, anxiety reduction, could be a talk of in itself. There's a lot of anxiety in the post transplant phase. But we kind of work with the ICU team, the lung transplant team, yourself, and the caregiver, to really come up with a strategy to reduce your anxiety. Why do we do this? Frailty, as Dr. Crespo alluded to, is frailty, and the prevention of frailty is crucial for post-transplant recovery. Frailty is the accumulation of deficits across all major body systems, respiratory included. It is independently associated with with being kind of out of shape, deconditioned, with delisting. Frailty is one of the criteria for our center's acceptance. Waitlist mortality and post-transplant mortality, as well as readmission into the hospital. These are two important facts that I would like you guys to know. Post-transplant muscle breakdown occurs within 24 hours after transplant. So we've done some types of studies where we've taken biopsies of your quadricep muscle, the big muscle that sits right above your knee, and there's evidence of changes, muscle breakdown, within the first 24 hours of you being in the hospital after transplant. Fact number 2 is we've validated this at our institution as well as other kind of peer centers throughout the country. There's a 30% loss in your quadricep muscle area in 10 days after post lung transplant. This is across people with different functional capabilities, those who are still unable to stand on their own versus those that are ambulating or walking in the hallways and doing some kind of weight bearing and standing exercises. So it doesn't matter how good or poorly you're doing, the 30% loss of quadricep muscle area occurs 10 days post lung transplant. So that's why this early mobility, early activity is crucial for post transplant recovery, for the success of the graft, and for the kind of improvement of your overall life quality. As I said, 7 days in the ICU, but some patients stay longer. This is an example of somebody who is critically ill, cannot stand on their own, cannot walk on their own yet, but still capable of rehabilitating in the intensive care unit. This is an example of the Moveo, which is a portable tilt table. As you see, this woman is kind of on the ventilator on trach collar, still has her chest tubes in place, but is able to exercise in a very critically ill state and exercises with a smile on her face. There we go. So that is a kind of some visual representation of what hard work looks like in the ICU. That's like Evan alluded to. This is another example, kind of somebody who is very, even probably a step sicker than the past patient. This patient is on ECMO and still able to rehabilitate kind of in the post transplant just by able to sit on the side of the bed and do kind of active leg exercises against gravity. All right, let me just like the video just froze right here. I'd be able to pass it through. Excuse me for 1 second. Let me just restart. Sorry about the technical issue. Let me just pick up where we left off here. All right, let me go back to where we were. Some patients stay longer. Once they progress out of the ICU, we go to the cardiothoracic step down unit. Medically, we wean the oxygen, we remove the chest tubes, close monitoring for acute rejection or infection. And just like you learned, there's a pretty intensive and rigorous outpatient schedule, which you start to learn more about. From a physical therapy, you get a precaution teaching is key. At this point, you're more mobile. You're walking independently or with a rolling walker or a cane even. You're able to stand up with assistance or on your own, able to take care of yourself, able to get yourself into the bathroom, washed, dressed, bathed, and then you're able to kind of demonstrate and hit the landmarks to be able to successfully discharge home or to the acute rehab, with the acute rehab under continual medical supervision and the home under the supervision of your caregiver, and come to the outpatient rehabilitation clinic. So some of the surgical considerations you see here, this is a picture of kind of a transverse sternotomy. We call it, you may hear it as clamshell. There's kind of mobility related precautions in the first 12 weeks. This patient's kind of centrally, the breastbone or sternum was cut in like a horizontal fashion, and it's a stainless steel is used to wire it back in place. And there's certain ways, every institution is different, and there's certain ways that you are not allowed to move your upper body or your trunk for approximately 2 to 3 months after transplant. Every institution is different. You learn about that once you're in the post-transplant recovery phase of your own medical center. The other kind of approach are we have right and left thoracotomies. You can see here kind of the chest wall mechanics that are involved. Not a lot of chest expansion here. You can see the incisions made under the right and left breast, and those black sutures where the chest tube sites are. You can see better on like a lateral or just a scans view here. This patient's in pretty good shape, actually. So once you leave the hospital, speaking about Penn Medicine here, you progress to our outpatient post-transplant rehab. We do a combination of pulmonary rehab and physical therapy. The respiratory therapists are the ones that are kind of run the pulmonary rehab. You progress over the course of 3 months, walking up to 45 minutes on the treadmill, or continuous aerobic exercise. If the treadmill was not practical for you, like Dr. Crespo alluded to, like you have a vertebral compression fracture or an orthopedic issue that will limit your ability to walk, we do have the lower body cycle or a new step if you've seen that in your pulmonary rehab program. What most programs don't have is a dedicated physical therapist to work on strength, balance, breathing mechanics, posture, and kind of higher intensity training. At our center, we tend to transplant patients who are a little more acute, medically acute, have a little higher score on the wait list. Those patients tend to be a little more frail, or have a longer course. They kind of post-transplant, they're more frail than they would like to be. So we kind of need that extra layer of attention and support in the outpatient center. So what does it look like? This is Evan. This is day 1 of Evan's post-transplant pulmonary rehab and physical therapy. It's a continuously monitored program. You can see the respiratory therapist is about to put a monitor on Evan as he does a 6-minute walk test. And it's a combination of aerobic training and strength training, along with breathing retraining, which is paramount in the post-transplant recovery phase. And our program works really well. There's close communication with the medical team regarding the response to activity. The first 3 months out of the hospital are crucial. A lot of medications get added, subtracted, up titrated higher, downgraded lower. And if Dr. Crespo changes a blood pressure medication, I'm sure she's going to want to know how the patient responds to activity. So that's why you're in this kind of controlled setting for the 2 to 3 month period in the post-transplant at our facility. The rest of this is going to be videos of kind of recovery, kind of to show you, kind of to put some images to what Evan was describing in his presentation. The video on my left of the screen is Evan's first time being able to stand without assistance of somebody, and without really assistance of using his hands on a walker or a cane. And just recall, Evan was transplanted in April, and this video was taken in October. So the first time we marked the occasion, and Evan is just on a little bit of oxygen for comfort. Again, personally, a little more complicated course than most, but we're able to wean him off the oxygen. This next video that you'll see is taken 2 months later, and you'll notice the kind of the stark difference in his capability here. Excellent. So then that's two months of continuous rehab, really focusing on lower body strength in your legs, in your glutes, in your calves, and in your trunk. to maximize your function, to be as independent as you can, and to live as high a quality life as you can. Evan's quality of life was lower in the picture that he couldn't stand up, or he could barely stand up because he still had to rely on others to help him. Now he's much more independent in these photos and videos. So to bring you back to the woman who was in the ICU, again, it takes a lot of hard work. This video is about 3.5, 4 months apart. But just to recall, you see her doing squats on the Moveo or the portable tilt table here. And then on the video on the right, you see her much more independent, able to stand on her own, a little bit of support in her upper body for balance. No oxygen, no feeding tube in her nose, no chest tubes draining kind of the post-transplant inflammatory fluid. And able to squat. And this is the young man who could do the lower body, who could barely do the lower leg extensions on the side of the bed. And then 2 months later, able to stand up with a lot of hard work independently doing our sit to stand test. So although those days in the ICU seem hopeless, am I ever going to get better? These videos taken just a couple months apart demonstrate that, one, our institution does not give up. We don't give up on you. And then you don't give up on yourself. And then you see kind of the outcome months later. And this is my plug here. This isn't just young folks. This gentleman is in his 70s. The video on his left is actually a pre-transplant assessment of him on a significant amount of oxygen in the outpatient center, doing one of our sit to stand tests. And you see, this is somebody who's in his early 70s, who's not frail, and is giving maximal effort with maximal oxygen support. Again, about 6 weeks later after transplant, he's only in the hospital for 2 months, and then in rehab for a month after. He's able to do the same test, no oxygen. You see a little bit of lower body shaking and weakness, but otherwise he's doing fantastic. So what are some rehab session exercises look like? This is a sit to stand with an exercise ball in your hand. Carm is training lower body strengthening. We're working kind of from you can see here she has a pad underneath of her, and she's working her lower body in that shortened range of motion, but still getting really good core, legs, and glute strengthening exercises. This is a little more intense. This is a younger person. He's doing a step up while holding 8-pound weights in his hand. And you can see behind, this is kind of what post-transplant rehab looks like. Other people walking on the treadmill in a monitored fashion. I'll play the video again, see if I can. Oh, sorry about that. Finally, again, another older individual after transplant working on core strengthening exercises. This is about 4 months after transplant. His precautions are lifted. We're in close contact with the doctor and the surgeon to clear him to stand in this type of position. And he's doing very well. Finally, balance is very impaired with the amount of medications that you guys take. One of the most common side effects is tremors, upper body and lower body tremors. So we really focus on balance activities as well. This woman, Carm, has a band around her leg, and she's doing some kind of focused stepping and hip strengthening exercises here. There we go. And finally, a little more advanced here. She's working backwards with close supervision from our aide and really working on foot placement, gluteal strengthening, as well as calf strengthening to be able to push back. You see, she's very wobbly. She's is a fall risk, but we are working on that in the video. And finally, last video is some upper body strengthening here. You can't do both arms behind the back at the same time here, so we do one arm at a time, working on some shoulder and lat strengthening exercises with John in the post-transplant phase. And then if you're lucky to be around as long as me, Evan will bring you birthday presents This is Evan during his post-transplant recovery phase, bringing me some cookies for my birthday in October of that year. So hopefully these videos and pictures have shown you guys that post-transplant recovery is challenging, but with the very supportive team around you, from the surgeons to your pulmonologist to your caregivers to your rehab team, that your quality of life improves, your overall functional mobility improves, and you're able to accomplish the goals that you want to post transplant. Because you don't go through a lung transplant to have the same quality of life like you had before. You go through to have a better quality of life and kind of to accomplish the goals in your life that you want to accomplish, like Evan has accomplished with his coaching career and his kind of work career. I just want to again acknowledge, thank you, Evan, for allowing me to share kind of these videos and these photos of your recovery, hopefully as inspiration to others who are on their own journey in the kind of the lung transplant process.
Thank you very much, Derek, for that great presentation, and I mean, extremely motivational. We are a little bit over time, so we won't be able to get to today's Q&A session, but I did notice a lot of our experts were able to answer many of the questions in the chat. If you do have any follow-up questions or any of your questions weren't able to be answered, please email me at asoto@scleroderma.org, and I'll put that in the chat. And I'll be sure to share those questions with our speakers and get back to you. With that, again, thank you so much for joining us today. I want to give special thanks to our sponsor, United Therapeutics. And I also want to give an opportunity for our speakers. If you have any parting comments for the audience, please feel free to share them.
Yeah, thank you actually for putting this webinar. It's and it's like I mentioned before. I mean, it has been really very, very actually like rewarding actually just to see how good Evan is doing and having such a great quality of life, and I mean, we have become actually like the entire transplant team has become their family. So, and I remember actually that he was a little bit he spent close to 1 year after the lung transplant here, and I think we have to actually like break that umbilical cord, because I think I remember that he was a little bit afraid about leaving Philadelphia.
I was, but you guys gave me all the confidence in the world.
Yeah.
Well, thank you again, everyone, and thank you to the Pulmonary Hypertension Association for co-owning this webinar. I hope everyone has a wonderful day. And again, this webinar is being recorded and will be posted to our YouTube page by the end of the week. I'll also send out an email with the recording and a link to a survey. Thank you so much, Dr. Maria Crespo, Evan, and Derek, and I hope everyone has a wonderful day. Take care.
Thank you, everybody. Bye.